Good day, this is Lian Ayade from Doctors College. We'll be discussing about anthrax. Anthrax is a disease of mammals, including humans, is caused by a spore-forming gram-positive bacilli called Bacillus anthracis. Anthrax is one of the oldest threats to humanity and remains endemic in animals in many parts of the world. The origins of anthrax are estimated to go back as far as 700 BC in Egypt and Mesopotamia. Rome and ancient Greece are also thought to have experienced the disease, with some considering anthrax to have played a part in Rome's downfall. The first official clinical descriptions were written by Marit in 1752 and retired physician Nicholas Fournier in 1769. After millennia filled with cases, true study of the illness didn't begin until the 1800s. These studies led to a breakthrough with a connection between anthrax and the animal hair industry. According to the CDC, this relationship even led to the name wool sorter's disease for anthrax. Rod-shaped bacterial bodies, eventually called Bacillus anthracis, provided the basis for major research from scientist Robert Koch in 1877. Through experimentation, Koch found the life cycle of the bacteria and demonstrated Koch postulates. More than a breakthrough for anthrax, Koch postulates set a precedent for all diseases. By studying the illness, he created a set of guidelines that all infectious bacteria must meet. After identifying the bacteria, researchers could work on a vaccine. In 1881, famed French chemist Louis Pasteur began research into a vaccine for anthrax. He injected 50 animals with live anthrax bacteria. While 25 of the creatures were given experimental weakened bacteria immunization, 25 were not. Results were clear. The 25 unvaccinated animals died while the protected ones survived. Around this time, anthrax began appearing as more than a natural illness. Anthrax was first used as a weapon during World War I by the German army. They used the disease to infect neutral parties, livestock, and animal feed, which was to be traded to allied nations. Further experimentation with the disease continued over the years, particularly during the Korean War. Bacillus anthracis, the causative agent of anthrax, is a spore-forming bacterium. The spores of Bacillus anthracis, which can remain dormant in the environment for decades, are an infectious form, but this vegetative form of Bacillus anthracis rarely causes disease. The bacterium causes disease through two mechanisms: toxemia and bacterial infection. Spores introduced through the skin lead to cutaneous or injection anthrax. Those introduced through the gastrointestinal tract lead to gastrointestinal anthrax, and those introduced through the lungs lead to inhalation anthrax. After entering a human or animal, Bacillus anthracis spores are believed to germinate locally or be phagocytosed by dendritic cells and macrophages. This will then carry the spores to the lymph nodes where they germinate. Bacillus anthracis begins to produce toxins within hours of germination. Protective antigen and edema factor combine to form edema toxin, and protective antigen and lethal factor combine to form lethal toxin. After binding to surface receptors, the protective antigen portion of the complexes facilitates translocation of the toxins to the cytosol in which edema factor and lethal factor exert their toxic effects. Bacillus anthracis disseminate to multiple organs including spleen, liver, intestines, kidneys, adrenal glands, and meninges, affecting their normal functions and leading to systemic infection with a potentially fatal outcome. The virulence factors of Bacillus anthracis are antiphagocytic capsule, toxins, protective antigen, lethal factor, and edema factor. Bacterial toxins. In order to infect the body, Bacillus anthracis must produce toxins. These toxins have three main toxic effects: edema, hemorrhage, and necrosis. Beside their direct toxic effects responsible for tissue damage, anthrax toxins are also responsible for interfering with cellular pathways in such a way that defense functions of the host immune system are affected. This will ultimately allow initial systemic infection by interfering with the immune system. When isolated, the three structural elements of the anthrax exotoxins are non-toxic. However, when combined, they form virulent exotoxins. Lethal factor and protective antigen produces lethal toxin. An edema factor and protective antigen produces edema toxin. The protective antigen is responsible for attaching the toxin to the cell, while the lethal factor and edema factor are responsible for toxicity. After germinating, Bacillus anthracis produces and releases into the bloodstream protective antigen, lethal factor, and edema factors toxins separately. However, protective antigen is secreted in its inactivated form. In order to form exotoxin complexes with lethal factor and edema factor, it must first be activated by host cellular receptors. The CMG2, or the capillary morphogenesis protein 2, predominant toxin receptor in vivo, and the TEM8, or the tumor endothelium marker 8, with a minor role. CMG2 and TM8 cleave PA20 into PA63 is the activated form of protective antigen, responsible for recombining with edema factor and lethal factor, thereby creating the toxin oligomer PA63 oligomer receptor complex. This complex will be internalized via receptor-mediated endocytosis within an endosome. The acidic environment within the endosome leads to the formation of a channel called the PA63 oligomer channel. On the endosomal membrane, lethal factor and edema factor are then released in the cytosol of the host cell to then exert their toxic effects. After experimentations in mice, edema toxin was noted to the major virulence factor since it caused death of mice in much lesser dosage than lethal toxin. Edema toxin is a calmodulin-dependent adenylyl cyclase known to increase intracellular COMP through the conversion of ATP into COMP, thus affecting several intracellular pathways. Lethal toxin is a zinc-dependent metalloproteinase known to interfere with the metagen-activated protein kinase, thereby hampering multiple intracellular mechanisms. Cutaneous or injection anthrax. According to animal studies, spores that enter the skin of susceptible animals germinate and give rise in about 2 to 4 hours. A small edematous area containing encapsulated bacilli. The following stages are noticed. The lesion increases in size and becomes defined by a zone of altered capillaries through dilatation, congestion and swelling of the endothelial cells, and through the epidesis of neutrophils. Macrophages and fibrin deposits appear and the efferent lymphatics become dilated. Continued multiplication of the bacilli in the lesion leads to fragmentation of the connective tissue as the edema spreads excessively away from the infection site. Necrosis and hemorrhage occur. If initial enucleation has happened with minimal number of spores, the primary lesion may be insignificant compared with that of the draining lymph nodes. The bacilli migrate from the primary lesion by means of the lymph vessel to the local lymph nodes where multiplication occurs, releasing with continuous stream of organism and toxin to the efferent lymph vessels and to the spleen and other lymphoid tissues where multiplication continues. In animals who died following subcutaneous challenge, the local lymph nodes became hemorrhagic and edematous. Necrosis of lymphatic elements and the blood vessels walls occurs and phagocytosis of the bacilli is apparent. Septicemia often occurs with splenic enlargement. Injection anthrax will have similar pathogenesis to cutaneous anthrax, but since it is injected, it can spread throughout the body faster, and it becomes harder to recognize and treat than the cutaneous form. Inhalation anthrax. Inhalation anthrax, the inhaled spores will be deposited in the alveoli first. From there, they will be transported within the phagocytic cells through the lymphatic vessels to the mediastinal lymph nodes where they will grow and cause hemorrhagic lymphadenitis. Bacteria escape from the damaged lymph nodes and invade the bloodstream and lymph vessels, potentially causing septicemia. At the same time, toxins are released causing the tissue damage and hampering the immune system to facilitate bacterial spread. Once the bacteremia and associated toxemia reach a critical level, the severe symptoms that are characteristics of the acute phase of illness are manifested. During the acute phase, damage of the lung tissue becomes apparent on the X-ray. This damage results from the action of anthrax toxin on the endothelium of the lungs capillary bed. Primary damage of the lungs is not normally a feature of the initial phase of illness, and primary pulmonary infection is an uncommon presentation. Studies in rhesus monkeys have revealed that after spore inhalation, its germination might take up to 6 days. This is the reason why antibiotic prophylaxis is recommended for 60 days. Gastrointestinal anthrax. In animal studies, the intestinal lesions caused by ingested anthrax spores range from focal to diffuse hemorrhagic necrotic enteritis of the small intestine. The tendency for localized lesions to develop in Peyer's patches suggests a possible role of the M cell in the uptake of the anthrax bacillus. Epidemiology. Anthrax occurs worldwide, and the World Health Organization estimates the annual global incidence of between 2,000 and 20,000 cases. It is rare in the United States, although in the year 2000, an outbreak of anthrax occurred in the ranches of North Dakota. Skin contact results in cutaneous anthrax, while inhalation or ingestion of the spores leads to inhalational, pharyngeal, or GI anthrax. Anthrax is categorized as a Category A priority pathogen by the Centers for Disease Control and Prevention because it is potentially capable of being disseminated as a bioweapon. Signs and symptoms. There are four common routes of anthrax infection, each with different signs and symptoms. In most cases, symptoms develop within 6 days of exposure to the bacteria. However, it's possible for inhalation anthrax symptoms to take more than 6 weeks to appear. Cutaneous anthrax. A skin-related anthrax infection enters the body through your skin, usually through a cut or other sore. It's by far the most common route of the disease. It's also the mildest with appropriate treatment. Cutaneous anthrax is seldom fatal. A raised, itchy bump resembling an insect bite that quickly develops into a painless sore with a black center. Swelling of the sore or nearby lymph glands. Sometimes flu-like symptoms including fever and headache. Gastrointestinal anthrax. A GI anthrax infection results from eating undercooked meat from an infected animal. It can affect your gastrointestinal tract from your throat to your colon. Nausea, vomiting, abdominal pain, headache, loss of appetite, fever, severe bloody diarrhea in the later stages of the disease, sore throat and difficulty swallowing, and swollen neck. Inhalation anthrax. Inhalation anthrax develops when you breathe in anthrax spores. It's the most deadly form of the disease and is often fatal even with treatment. Initial signs and symptoms include flu-like symptoms for a few hours or days, mild chest discomfort, shortness of breath, nausea, coughing up blood, painful swallowing, high fever, and shock. Acute medical condition involving collapse of the circulatory system and meningitis. Injection anthrax. This recently identified route of anthrax infection has so far been reported only in Europe. It's contracted through injecting illegal drugs. Symptoms are redness of the area of injection, significant swelling, shock, multiple organ failure, and meningitis. Diagnostic workup. Your doctor will ask you about what kind of work you do along with other questions to determine likelihood of your having been exposed to anthrax. He or she will first want to rule other more common conditions that may be causing your signs and symptoms, such as flu or pneumonia. You may have a rapid flu test to quickly diagnose a case of influenza. If other tests are negative, you may have further tests to look specifically for anthrax, such as skin testing. A sample of fluid from a suspicious lesion in your skin or a small tissue sample may be tested in a lab for signs of cutaneous anthrax. Blood tests. You may have a small amount of blood drawn that's checked in a lab for anthrax bacteria. Chest x-ray or computerized tomography or CT scan. Your doctor may request a chest x-ray or CT scan to help diagnose inhalation anthrax. Stool testing. In order to diagnose GI anthrax, your doctor may check a sample of your stool for anthrax bacteria. Spinal tap. Your doctor inserts a needle to your spinal canal and withdraws a small amount of fluid. A spinal tap is recommended anytime doctors suspect systemic anthrax. Treatment. Antibiotics are usually used to treat anthrax. Antibiotics that may be prescribed include penicillin, doxycycline, and ciprofloxacin. Inhalation anthrax is treated with a combination of antibiotics such as ciprofloxacin plus another medicine. They are given by intravenous. Antibiotics are usually taken for 60 days because it can take spores that long to germinate. Cutaneous anthrax is treated with antibiotics taken by mouth usually 7 to 10 days. Doxycycline and ciprofloxacin are most often used.